Thank you. Hello, Barry.
Hi, Diego.
Hello, how are you?
Thank you. Okay, how are you?
Thank you for coming, yes. I think we are waiting for a few more people.
Okay.
Yeah. Would you like questions at the end, Barry?
Yeah, that's fine.
That's fine.
Absolutely fine.
Okay.
Whatever people prefer, but I think, yeah, probably at the end would be the best.
Yeah, it should, about 1 hour it should take. Yeah, otherwise people, yes.
Well, listen, I have a number of slides, but and I'm not sure I'll get through all of them, but I'll do my best to kind of skim through a few bits and pieces.
Yeah. Very good.
And I'll try and leave a few minutes at the end for questions.
Okay, fantastic. Yeah. So I think it's 7 o'clock now. Hello, everybody. Welcome to this new webinar with the ICO and Osteopathy. Today, I'm very happy to introduce Mr. Barry Jacobs. He was my teacher at the BSO of clinical methods. I remember him very well, and he was a great teacher. Yeah, and well, he's an osteopath from the BSO from the 1986, I remember. And so, welcome, Barry, and I'll let you go in. Thank you very much.
Thanks. I've got to make sure I can get this right, Diego. That's the only thing. I'm going to hit share and then this.
Yeah, that's fine. Yeah.
Have I done that properly?
That's on the screen now, yes.
Okay, get that out of the way. Okay, hello everybody, and thanks for joining me and us at this webinar. Basically, I was now called University College today, formerly the BSO, and we were talking about the importance of retaining our diagnostic acumen as osteopaths. Some people like to think of clinical diagnosis as an art, and I think, well, certainly there's a great deal of judgment involved, and that judgment requires an enormous amount of rumination, and that rumination has to be driven by the capacity to perceive possible hypotheses. That's one of the things that really distinguishes us from some of the other clinical professions, but certainly the capacity to actually drive ideas about what might be happening idiosyncratically to our patients, but of course supported always by the deep clinical education that we have. And I think one of the areas that's always been very difficult and remains difficult, and by definition, is trying to actually pick out the possibility of cardiovascular disorder from a routine presentation. Now, I'm not talking about necessarily overt red flags. I'm talking about, because I think red flags are a very limiting notion, in that effectively, if you have a subtle appreciation of the variant ways in which physiology behaves, then you will start to want to pursue those ideas, as you will with everything else. And essentially, hopefully, those ideas can actually be reconciled to the consensus, So I'm going to just briefly talk today about a few old concepts, but some of the most recent ideas about what actually might be important. So today's presentation is called Picking Up a Dicky Ticker. A pragmatic approach to critical cues. That means in the history, predominantly cues that might help preserve life and limb in osteopathic practice, and effectively those things that might present to us in practice. But certainly I don't want anybody using the term red flag, because red flag would imply a very overt and pre-prescribed list. I think we have to look more at subtle physiology, and that nothing less should be deserving of the osteopathic profession. Anyway, moving on, let's look at the common presentations of cardiac conditions in osteopathic practice. I think I'm going to try and move us out of the way there if I can. I don't know if people are seeing this on the screen. Patients with thoracic pain, patients who are faint, dizzy, or lightheaded, we kind of see that sort of thing all the time, don't we? Now again, let me be absolutely explicit about this. It doesn't necessarily mean that these things exist in isolation. It's like everything else that we see. We are used to presentations which are in context, and we'll talk a lot more about that in a moment. But here are just some of the things that might get you just thinking, and always will probably get you thinking. Nausea and epigastric pain, pretty important. Breathlessness and fatigue. I have no idea why palpitations came in there second. Palpitations in particular, so awareness of the heart beating And this is, again, not an uncommon phenomenon. Most of the time, virtually all of these things will be entirely benign. But I can't emphasize sufficiently how important it is to try and see these things in context. Impaired activity, so people feeling fatigued or just can't move themselves or feeling stiff or just don't feel they have energy to do things. Swelling, patients with lower extremity pain, very important, not just in terms of central, but we have to think in terms of peripheral cardiovascular disease. There are plenty of others, but these are just common ones. A couple of histories here from my practice over the years that have actually resulted in cardiovascular diagnosis. We have a 41-year-old male property developer. He had pain in his left low back presenting with radiation to the calf. And you think, well, that's pretty straightforward. And it did seem to be mechanical, gradual in onset, and certainly aggravated by walking, especially over that last year. But he did have a very specific neurogenic form of radiation as well, which is interesting. No pins and needles or anything like that, but certainly persistent pain even after walking. So it didn't just go off with rest. That's a big kind of differentiating issue, you'd hope. Occasional trouble, the old how's your father, he said. And that was his euphemism, of course, for erectile dysfunction. Significant cigarette smoking from the age of 18. And he actually put his cigarette packet down on the reception desk, which was pretty explicit. Gross familial hyperlipidemia, so an important history there. And increasingly, we realise that genetics are very, very important, possibly much more than anything else in terms of lipid levels in blood. Certainly, the old notion of dietary control, we were always told pathologically it was a nonsense. Much of it, I'm told, was driven by the margarine industry, dating back to the 50s and the Blue Band Company in America. But now we actually recognise, and studies have demonstrated, that diet plays a very tiny role actually in lipid control in cardiovascular and general disease. And he was on no medication. So an important one to be thinking about. If we get an opportunity to return to this, I would like to. But no, in fact, what I'll do is I'll just talk about it. In fact, this chap ended up with a condition that actually revolved around obstruction of his, I think it was his femoral artery actually. He had an audible bruit in his leg, I beg your pardon, his inguinal area. So obviously, as you know, that was caused by turbulence due to a change in the laminar flow of the vessel. But he also simultaneously had a bad back. You know, so of course, there's some of the leg pain, some of the calf pain overlapped, but he did have a very explicit calf problem. And I will come back, a femoral artery problem, and I'll come back to talking about that a little bit later. Some of the other stuff I'm just going to talk about in a moment. Right, so here's another one, 61-year-old avionics engineer who has now actually moved to Scotland after having known him for 2 decades. Complaining of his typical left-sided neck pain radiating to the shoulder. He noticed it last few days in the cold weather, so there's a big clue there, of course. Painful on turning the head, ipsilaterally, so if you turn his head to the same side, it hurts. You think, is it mechanical, is it not? And is it still feasible? The person with a viscerally driven condition might actually also have a mechanical or somatic component to it. You know, again, old territory, we think for osteopaths, but physiologically and evidence-based position is that, yeah, why not? That was the big one. He said, by the way, a funny thing was, I was standing there and I am asthmatic, as you know, and it was relieved by my inhaler. So that was a really important clue, because of course he was actually causing, but not only dilation of his airways, he was also probably having an effect on his heart as well, or at least he was providing enough oxygen to make things a bit easier, maybe. And he was generally fit and well, but it turned, as it happens, I packed him off to the medics, and he was actually in the middle of an ischemic attack. He was actually having a heart attack. Here's a 36-year-old nurse presenting with interscapular pain. That's quite important. We see that all the time. She does, or did have a proclivity for fainting, feeling a bit peculiar, she said. And 2 kids with bowel issues. So, and she was a kind of a stressy type of person. Previous history, otherwise unremarkable. Nil else. Now, again, that could be every other patient we've seen. We know that person with young children, she's under a lot of stress, etc. But the fainting is important, and that's quite important. So moments of syncope especially as it happens on standing up, and people will immediately think, well, possibly that's a postural hypertensive type scenario, but there are other components to that which I hope to come back to later, but that was actually to do with a kind of extreme version of postural hypotension, which is generated by autonomic disorder. And effectively, she had something called POTS, which I'm sure people have heard about, and that's a postural orthostatic tachycardic syndrome. So basically, when she stands up and dumps blood into her lower extremities, she wasn't recovering, wasn't keeping things going sufficiently, and the heart rate will go up very fast but ineffectually, and people feel faint. And we can do tests for that, which we'll talk about. Last one, 57-year-old primary care clinician, right-sided chest pain, on exertion, cross-trainer 4 times a week. Interesting enough, pain was variable, can be subscapular or epigastric. I have no idea why epigastric is in that font. I cannot imagine why it isn't there, but I think I kind of like it. Abolished by Gaviscon, that's interesting. So antacids, that sort of thing, antacids, often play a role in differential diagnosis. Subscapular pain abolished by erect posture. That's interesting. So standing up seems to make things feel better. And the previous medical history is otherwise unremarkable, fit and well, nil else. Now I'll come back to this one in a second, I think. Right, so where to go next? So these were just examples of stories, and again, I am kind of racing through, I appreciate that, but these are just examples just to whet the appetite for people to kind of think about these things a little bit, I think. What shall I explore now? This is the basic osteopathic premise. Symptoms are caused by altered function, governed by altered structure. In other words, we all know this. If your structure changes, then presumably the physiology associated with that structure will be corrupted and will be manifest as signs and symptoms. And people present with those signs and symptoms, and it's up to us where we can to try to understand or try to conjecture where that thing's coming from. So where is it, the tissue causing symptoms? In other words, this has got to be coming from somewhere. Later on, we then say, what is it? You know, what is the nature of the thing that has insulted that structure? You know, most of the time we deal predominantly with degenerative and traumatic, but there are other things like neoplasia if we're unlucky. So people do sometimes have cancers affecting things, or metabolic such as osteoporosis, or etc., etc., etc. But effectively, this is the critical bit, the why. And here's the real osteopathy, the predisposing factors, maintaining factors. What is it in the background of that person, that idiosyncratic history that gives them what they've got? And just to make it just a little bit more difficult, can we distinguish between one thing and another? Sometimes we can't, and where is the balance of probability? You know, do I think this is really the shoulder? Am I even concerned that it might be their cardiac situation? And if so, should I do something about it? So it can be difficult, and often there aren't clear answers. Here's a more explicit example. What I've just been talking about, this is something that Lawrence Butler, my esteemed friend, some of you may remember him from the BSO and may have heard him lecturing a great deal. He used to teach this kind of thing in the NHS, teaching extended scope practitioners, that sort of thing. You know, really, as osteopaths, we say the function is simply the presenting sign. It's the thing that's gone wrong. We reconcile it to a tissue. We then say, okay, what else does it do? A lung breathes, an eye sees, a hip articulates, and load bears. How can I test that behavior? And can I kind of show itself? Can I make it reveal itself by going wrong? We do that every day with everything, and the heart is effectively the same, but essentially we do predominantly with history and asking questions. And if we're very lucky, we may just get to corroborate on examination. But remember, the history is the key thing. There are numerous references here. Many of you will have come across these books. I mean, nowadays, I'm particularly keen on, as it happens, on this thing here, this Medscape. Love this. Virtually any subject you put into Google, if you just put e-medicine first in your search and then your subject Parkinson's or something like that, or Klumpke's paralysis or whatever you want to put in, carpal tunnel syndrome, you will get a very, very up-to-date notion of what's going on now. Jobbing clinicians will have actually contributed. Absolutely fantastic resource that. Don't know that it's necessarily going to completely abolish the others or make them redundant, but it's very, very useful. And of course, the old journals that exist. Right, so just to be absolutely clear, the history is all. History is all. Here's the current and still prevailing nice guidelines. I'm sure if you haven't had a look at these are a useful resource, but this is kind of looking at what the NHS says, and it does have some value for us. Certainly what GPs are confronted with all the time. The 10 steps before you refer for chest pain, based on the British publication, British Journal of Cardiology here. And as I said, these are still prevailing, and really everyone here will recognize this sort of thing, very old-fashioned, but useful and reconcilable to our kind of background. Take a detailed history. The cornerstone of diagnosis of angina pectoris, typical characteristics of chest pain that increase the likelihood the pain is caused by his angina and coronary heart disease. And now some probably refining ideas about the history here. Stable angina. Now we're talking about stable angina. So this is characterized effectively by a predictable cause and effect scenario. So duration is short, it's worse in cold weather after a meal, for example. Exertion, particularly important. And they've said here, you know, physical emotion or physical exertion or emotion relieved by GTN if you've got that available to spray under the tongue, that sort of thing. Good old-fashioned, you push your luck and it happens, but it's predictable cause and effect. And here we go for the current clinical classifications of that. Typical angina, definitely they're saying it's 3 of the following characteristics. Substernal chest discomfort, characteristic quality, we know about that. That's that deep, often pressing, crushing pain people get centrally, provoked by exertion or emotional stress, relieved by rest and or GTN. And they're saying the typical angina will meet 3 of these criteria. So that's all 3 here. If it's atypical, then it may meet 2. And that's where we see a lot of this stuff, because those atypical patients may come to us. So they may just have a bit of substernal pain. It may not be provoked by exertion. And of course, we haven't got the GTN, but stress is something that we see a great deal of, as does everybody else. Stable angina descriptions, again, type of discomfort, often tight, dull, heavy. Look at the radiation here. Chest, of course, radiate to the jaw, potentially shoulder, back and arms. Elicit, again, know what to ask, physical exertion or emotion. Although, again, esophageal spasm may respond to GTN, they say. Duration may be several minutes after exertion stress has stopped, so it may go on for a bit longer after the person's got off the machine or tried or whatever. And of course, exertion in the cold, running up steps, that sort of thing. Now, in unstable angina, here we're in a different scenario where it doesn't seem to be predictable, so even more difficult, more prolonged, more frequent, may occur at lower thresholds, or even at rest. Patients who are considered to have unstable angina should be admitted to hospital acutely, and their management is not included here. So effectively, if you are worried, again, all of this stuff, but unpredictable. So if you think, yeah, they're getting that pain constantly, if you're in doubt, very low threshold of suspicion here, get them sent off. And things have changed a great deal. Now they will actually take them straight in. One of the general hospitals recently told me they're doing 200 CT scans for coronary artery. Now, I don't know if people are familiar with CT-CAR. Coronary artery CT scanning now is a big, big deal. It's virtually bypassed everything, you know, even before they bung people on, sometimes before they bung people on a stress ECG or even before an echo. They can just straightforward just image the coronary artery, the coronary artery circulation, and really just have a look for obstruction straight away, even emergency stenting, the balloon angiography if they need to. So, and they're doing loads of them now. The only trouble with CT-CAR is it does slightly over-exaggerate the amount of obstruction, but these are critical. So if you think somebody's got this unremitting pain, don't know why, and you know what to ask, you know, cold weather, lying down, standing up, doesn't make a difference, no, it's always there, you know, exertion, or it just really happens easily. Again, the best guidance for us all as experienced clinicians is knowing what's normal, and normal is variable. Normal is the pattern, remember, not abnormal. Normal is the pattern. It's very, very variable. You think this isn't right, it can be referred straight away, and nobody will actually think that you didn't do the right thing. Now, consider the non-cardiac causes of chest pain. They're usually, again, differentiated by careful history taking, esophageal disorders, reflux, dysmotility. They can be characterized, you hope, by burning, acid reflux, relief with antacids, positional sometimes at night, which we haven't got there. Here's a nice table of some of the other fat components. And there's a lot in there. You can look these up anywhere. The one I think we particularly like is this one here. T.E syndrome, which is mechanical pain, usually the costosternal or the costochondral junction, or pain referred from the thoracic spine. And remember, this is all in context. It's all about age, exertion, when the person's doing at the time, all of those things. You know, chest infection, my God, are you going to just say, oh, it could be a chest infection without ask any other questions? We know what to ask. Moving on. I know people probably want to see this, but I'm not sure whether we can make the slides available afterwards. Quite happy to do that. So the risk factors. Now, this is the kind of thing, the algorithms that they use a lot of the time in the NHS, and GPs will often fill the whole thing in. You can see there's information here on smoking status, diabetes, angina. You'll notice that they actually pay attention here to severe mental illness. And that's either going to be for differentiation or because patients who are stressed, or maybe because it may be something alternative and they're becoming anxious about it, or increasingly there is a concern about stress. There is an increase about stress and its effect on sleep deprivation or cardiac diseases. There is for a lot of other things. And interestingly, there's erectile dysfunction there again. So maybe the person has some degree of peripheral circulatory disease already. You know, there are clues. You just need to know what to ask, I suppose. We have also, of course, inflammatory disorders included in there, both rheumatoid and SLE. These are interesting guidelines, but the really big thing that changed quite a few years ago, actually, was the arrhythmia. I remember I spoke briefly about people with changes in pulse rates or awareness, I should say awareness of their own heartbeat. Of course, when I say change in pulse rate, they will say, I've noticed aware of my heart beating, they have palpitations. And atrial fibrillation, which everybody appreciates, is irregular, in other words, completely unpredictable pulse rate, or pulse rather, used to be relatively dismissed. They might give digoxin for it or whatever. But in the last 20 years, especially in the last 10 years, it's become a massive source of interest because, of course, atrial fibrillation can cause, as we know, or does cause a dyskinetic atrium, and a dyskinetic atrium can generate neural thrombi and other type of thrombi and inappropriate blood flow. And of course, the cardiovascular morbidity and mortality are very significant when associated with that sort of thing. So people who are at a much higher risk of stroke, and the whole new now host of anticoagulants, now like apixaban and clopidogrel and so on, are now being used. Massive interest in atrial fibrillation and arrhythmia now in terms of stroke prevention. So these kind of things are freely available to try and work out risk. Here we've got our lipids here at the bottom, blood pressure and so on, of course, and I'm coming on to some of that. So establishing the risk factors, we talked about that. After that, performing a physical examination. Now again, please permit me to stress once more that we have all sorts of things here that may be valuable, but the history is the key thing. And we are all, again, familiar with this sort of thing. Weight and height and calculation of body mass index. In fact, that may actually even already be out of date, because increasingly many studies are now moving towards this second item here, which is the notion of comparison of waist circumference to hips. Very interesting. They're saying metabolic syndrome here, otherwise pre-diabetic patients, and the NHS is profoundly burdened, as in the rest of the Western society, with the idea of diabetes, of course, and pre-diabetes. But this idea of comparing hips to waist, and I dare say everybody's got a nice flexible tape measure in practice. Just compare if you are concerned, compare your patient's waist to hip ratio, and in men, it's supposed to be about 90%. So your waist shouldn't be any greater than 90% of your hips, and in women, 80%. If it's higher than that, then the implication is that there may be a higher cardiovascular risk. So waist should be 90% of the hips, maximum in men, and 80% in women. And I may actually be trying to do something about that myself at the moment, which is making me very miserable. Again, blood pressure, of course, which we'll talk about. Murmurs are important, especially aortic. one of the reasons we're interested in valve damage actually is because it's so close to the SA node and may be linked to arrhythmia as well. But there are obviously plenty of other components, i.e. poor output and the proclivity for left-sided heart failure. The others will speak for themselves, to do with lipids. And of course, again, we talked about peripheral vascular disease as a clue. I'm going to talk a little bit more about that moment. And of course, anemia and thyroid. Thyroid, particularly if a kid turns up with an arrhythmia, often they'll say that the first thing they want to look for is thyroid, and thyroid, so one of the strongest causes of arrhythmia in kids is thyroid. But and one of the earliest presentations of thyroid in older people is arrhythmia, but not the common cause of it. Wanted to get that out of the way. Now, so the three here we're talking about the relatively recently adopted terminology. Not everybody may be familiar with the acute coronary syndrome, and again we're talking about people suffering angina and chest pain as a consequence of, and worse, ischemic heart disease as a consequence of coronary syndrome. There are three main types, and they're really driven by ST changes on the ECG, so not so critical, but effectively everyone will know about this, the Stl Segment Elevation. You can see this, as you know, is that after the QRS discharge, we've then got the repolarization phase here. And of course, as we all know, in an ischemic attack, at least in the initial stage, that actually may be elevated. We can lose that dip there. That's not an uncommon phenomenon. Later on, you actually may see as the tissue further ischematizes, you may see that as a drop on a person's ECG. So we've got we've got the two types. You know, in other words, a person may have or may not have changes. So a person can have angina symptoms, but no change yet on an ECG, which is great news, of course, because it implies there may or may not be, hopefully they may have escaped actual ischemic damage to the myocardium. So hopefully they've managed to get away with it. But and then, of course, the last is referred to as unstable angina until further investigation is made. And again, they may actually go ahead and perform, in fact, they probably will perform CT-CAR. So I just wanted to emphasize what I said again earlier, which is that the dietary contribution to blood cholesterol and so on is virtually, not, I wouldn't quite say a myth, but virtually a myth now. And people shouldn't be banging on about trying to get their people's lipids down by dietary control. There's every reason for people to lose weight. Obesity, massive contributor to heart disease, as is smoking. And personally, I'm not a fan of any of these kind of places, but we can't blame them all for the heart disease based on cholesterol content. But everything else that you might think of, please be my guest. Just to emphasize the point, there they go. So here's something really very useful. Now, here's a typical reflection of atypical chest pain distribution. This is a great one. I don't know if you want to screenshot this at home, or if you can. I love this picture. But here we've got a comparison between people with cardiac pain and the kind of variation that they may actually experience. Like 100% here, they're saying very, very commonly that they'll get it there. Let me just emphasize, that doesn't mean everybody gets it there, but it's very, very, very common. There will be people who just present. I heard of one person who just had it on the tip of his nose, and only when he was exerting himself, and I won't tell you how he was exerting himself, but that is kind of a notorious case. All these other areas may, even in isolation, potentially be sources of pain. Fascinating. I think they say 100%. It's probably more accurate to say 100% suspicion there. And look at the overlap there with esophageal pain here on the right side of the screen. Interesting here, look at that, in the kind of dorsal lumbar kind of area. Quite common, look at that, cardiac pain there, up to 30% nearly. And so we shouldn't really be sneaking around and assuming that it always goes up into the left side or left arm. There's quite an interesting and typical presentation on the other side. But classic into the neck, may go into the jaw, may go into the face. And this is actually, I'm told, this is a common presentation in women, in middle-aged to young women. So just talking about examination, all of these devices are useful. Thermoscope, torch to look in the gob, the eyes, tape measure we've talked about, and also useful for tape measure for measuring swelling, that kind of thing. Nice classic stethoscope, that's been on, that's our old favourite. So you've got a bell on the top there for low frequency sounds and for getting into the nooks and crannies, and the diaphragm underneath it. Although if you press hard enough with the bell, you turn the whole chest into a diaphragm. I still like an aneroid SVIG, and I do know a number of cardiologists who say the same thing because it's much more reliable than digital, although there's a big market digital, and there are certain things you can do with a SVIG aneroid that you can't do with digital. But you know, here's the kind of the new generation coming out now, where you can do everything with that, I presume, including making a microwave meal for 4 people. And but I still prefer the classic. An increasing number of apps, apparently, and I think there's been talk recently about people even soon being able to perform I think to be able to even perform an appropriate, viable ECG or take blood pressure is based on looking at the change in the finger, or light change of the finger, or something like that. Can't remember, but that'll be useful. I think oxygen sat should be possible. OT sats can be achieved even with very inexpensive equipment. You get that on Amazon for about 18 quid. How reliable they are, I don't know, but probably quite useful. But moving on. So again, a recap of things we're interested in. Presenting history, of course, critical. We say that previous history. So stuff that people have gone through before, their social history, smoking, drinking, exercise, and of course, family predisposition now be considered to be critical, absolutely critical. So you know, early death in the family, or elevated lipids and so on. This is the classic picture here. This is a lovely Netta picture, probably from the late 50s, I should think, and you can see that this gentleman has just come out of well, you know, he's of a certain age, and as you can see, he's obviously presumably had an empty meal, and he's dropped his cigarette because, of course, he's clutching his chest, and he's also making effort. He's been up some steps. It's snowy, it's cold, and he's lugging a suitcase as well, or he was lugging the suitcase. I've only just noticed after all these years that he's actually in the process of dropping the suitcase. And in there they give you the classic depiction of pain, but of course we know that no longer to be the case. So there's a classic story. So history is vital, and there may be numerous things that people talk about. Claudication of limbs, autonomic dysfunction, we talked about that before. People who suddenly may be inclined to dizziness or fainting, urinary disturbance, of course, because of inappropriate renal function. All of these may be vital. When we say dizziness and vertigo, it depends on what people say. True vertigo, we absolutely appreciate, is a hallucination caused by either the 8th nerve or central nervous system, but certainly, depending on what people say, whole list of things I think everybody can reconcile themselves to there. Here's again, this is derived from the most up-to-date NICE guidelines, last updated November 2016, for presenting stable chest pain. And this section of guideline addresses the assessment and diagnosis of intermittent stable chest pain in people with suspected stable angina. So again, a useful resource if you just want to double check it. Pretty much a reflection of what I've just been talking about. So where do we go next? What do we actually look at? And it may just be that you want to have a nice reflection of effectively what people do in their lives, when they get them in, how fit they are, what they're predisposed to. These are just a few of those components. Stress, and I should really put sleep deprivation in here as well. These are all considered critical now factors in the development of disease. Here's the really enormously important and virtually, I'd say, eclipsing component cause, because this is the thing that may precede diabetes. And when I say diet, again, can I just stress, please, I'm not talking about dietary cholesterol. I'm talking about people who are predisposed to obesity. Of course, travel, and I'm dotting around a bit, of course, but I have to, because this is under this section. But of course, I will be talking here predominantly about people who may have peripheral vascular disease, particularly venous disorders here, and predisposed by being static over a period of time. It doesn't just have to be long haul flights, but being static and dehydrated potentially. Again, the all-important family history: ischemic heart disease, premature arterial disease, we've talked about, hypertension, which I'm going to go on about in a moment, hyperlipidemia, and of course diabetes. And there's a horrible list. Again, you can find this virtually anywhere, but just scan down that for a moment and you'll pick out all the contemporary things. And I'm sure there'll be things that people can think of that I've probably missed out, but these are just a kind of few of the highlights. What's interesting here is that we don't really see much in the way of cyanotic heart disease anymore, congenital stuff, but we certainly see this hypertrophic obstructive cardiac myopathy, the developmental overgrowth, if you like, of an obstructive kind of myocardium. People used to see that as a death sentence in their late teens, early 20s. Now people live full lives with it. We really have moved on. But everything can be important if it's in history, and it's critical to try and find these things out. Again, here's another depiction of the same sort of thing from Nice and Similar. There they just reconciled it down to ischemic heart disease, hypertension, diabetes, mellitus, and they do include valve disease, very important. And a lot of procedures included for heart valve replacement now, quite virtually routine now. Breathlessness, fatigue, ankle swelling, of course, impaired activity, we talked about that before. Look at the lovely list here. Pulse rate changes, particularly rhythm, blood pressure raised, JVP we'll talk about second, due to right-sided heart failure. Don't see many of those, thank heavens, but for people who have been chronic smokers or bronchitics, obstructive airways diseases, all these things may be important. Infections on feeling unwell, and they say hidden by edema. In other words, the person's got swelling but underneath it, they're obviously feeling exhausted, or maybe they're ill because some underlying disease process, that sort of thing. Again, all of these things available. Have a look on the NICE websites if you want clarification. Okay, so right. I'd like to just remind everybody of their anatomy, their circulatory anatomy, when I'm talking about forward effects and backwards effects. Obviously, this is I think this, I may have actually got this from an O-level book, GCSE books. I like this. It tells us, remember that the aortic valve there, if anything's going forwards and it's obstructed, you get poor peripheral circulation. If it's and you get backward effects as well, resulting in heart failure. Anything backwards, that goes back into the body from the right side. I'm not going to dwell on this. Just a nice little line. But there you go. There's a venous disorder. I've been using this. I don't know how old this picture is, but it's a lovely one. And sometimes there's argument over which limb it is, whether it's an arm. I think that's an arm. May well be. Some people may well think that's a leg, but I think that's a lower extremity. I think that's an arm. A good old-fashioned swollen ankle there. Look at the marks there, the indentations. There's nice pitting edema from a sandal. And again, I'm going to just whip through these. So many of you have seen those. There's a poor guy. He looks a bit jaundiced as well. But he's probably got left-sided heart failure. We can assume he's got right-sided heart failure there, or hepatic portal hypertension. But maybe he's got a horrible mass in his liver or something like that, causing a backwards effect there. Good old-fashioned Zatteroff picture here of somebody with again with edema caused by right-sided failure or right-sided venous obstruction. It's right-sided effect anyway. Then you can see the fingerprint there after the finger's been removed. Horrible superficial venous distension there caused by some sort of hepatic or hepatosvascular effect there. The inferior vena cava possibly, or the hepatic portal vein there. And in this case, this chap, unfortunately, is very old-fashioned. He looks pretty ill there. He's had surgery. This actually, strictly speaking, is not a cardiovascular case. This is a person probably with, unfortunately, a nasty hepatic condition. But he has had surgery, and this is the picture on the left is the one he's after he's improved a bit, actually. He's probably had a radiation and so on. It's tattooed. All right, so just a quick reminder, therefore, about the JVP. They mentioned the JVP in the guidelines, and everyone remembers it's important to look at the internal, not the external jugular vein. Lies between the two heads of sternocleidomastoid, and the reason we look at the internal to the external may well get obstructed or kinked in the superficial soft tissues of fascia. Very hard. You can virtually impalpable. You can certainly see it, and as you remember, there are some very particular characteristics if you stick the patient at 45 degrees semi-recumbent, and you'll see a double-topped pulse. Certainly not going to bore you with all that at the moment. But there's remember, it's position dependent. It's low pressure. You can't really palpate it. Double-topped because it's such a low pressure wave that it effectively reflects everything that's going on further down the line at the heart. And if you press their abdomen, you may actually even see it expand in some people's cases. Remember, if you lay the person's right flat, it'll disappear, and if you because it'll go up at the top of the head, so you won't see the top of the column. And if you sit them up, it'll disappear also because it'll drop down. And the main movement is said to be inwards if you look carefully. Here's a nice picture of a JVP, and this one is supposed to be an example of a person who's not too well, but I think, and you can see they're shining a light on this as well, but actually that isn't too bad, but it's supposed to be somebody with a bit of failure. I don't know, I don't like what she's wearing anyway, but that's probably not anything to do with it, I should think, but don't dismiss things. Looking at the face, here's the typical example of warty vegetation, xanthus stomata around the eyes, and I could probably include an arcus senilis there, deposition of lipid products throughout in the iris. Looking for signs of anemia, of course. Sorry, I'm going to have to, and gingivitis, probably this person's not too well off either. And again, maybe a predisposing factor to illness. There's another lovely netta picture of somebody who looks more like ET than a cardiovascular patient, but you can see they're actually showing evidence of clubbing and cyanosis. They've probably got chronic heart disease at her age. I'm sure this would have picked up long before, but there's a patient of mine with very vivid, conspicuous digital clubbing in the toes there. They've got typical beaking, as you can see, and they've got enlargement there of the distal digits there. There's a classic, and I think that one actually was just idiopathic. You may see that as a sign. If you see that as a sign of disease, I think things have really dragged on a bit. There's a lovely further example of the same sort of thing. Peripheral pulses may be of value. We talked about looking at the patient before who had peripheral vascular disease. You know where they all are. Again, I'm not going to stress these, just a quick reminder of the list. Again, depending upon the history, if the person's got pain or if they look like they're claudicant, you obviously would observe for local signs of insufficiency, so hair loss and colour loss and temperature change. You try and palpate for volume, compare for strength and delay, and everyone remembers delay. Remember, you can compare to the two different vessels, like the radial and the femoral, or the radial and popliteal, before and after the area you suspect to be obstructed. If you think it's a claudicant phenomenon, especially if it's affecting the femoral area, you can auscultate for a bruit, which is the one a patient I told you about before. Now, this is a really interesting test. This is something that we love because it actually provides some objective comparative evidence. This is comparing the ankle and the arm. And but before I talk about it, let me just finish again looking at Postural. This is a fellow who actually has got a bit of an issue there with a quite a big pressure, the difference between his systolic and his diastolic. And that's because he can generate a nice systolic pressure, but the problem is got an aortic regurgitation. The aortic valve is actually a little bit wasted. Fluid is coming, blood is flowing back into the ventricle as the ventricle is relaxing. So instead of actually being held there by the aortic valve, it's flowing back in. And he's got a kind of bounding pulse, and you can see it's a singular pulse. It's not a JVP. This is a carotid effect. You can see a similar effect here in this person's fingers. This is called Quincke's test, a Quincke sign. And you can see because they've got a bounding pulse, it's not thyroidal, it's because of this big up and down wave that they're getting because of aortic regurgitation. What used to sometimes be called the same sort of thing as a water handle pulse. You can exaggerate the effect by raising the arm because, of course, the blood's flowing up and down all the time, up and down. So soon as they get the systolic part of the pulse, and then the thing just collapses back down again. It's a lovely little depiction of it there. And here's another example here in the brachial artery. So a overt brachial pulse, again, because of an aortic regurgitant issue. Right, let's talk about that ankle-arm ratio. I love this thing. Right, now, all you're doing is comparing the lower extremity to the upper by palpation. So you're only testing the systolic component. This is a really nice pearl that you can take away if you're not familiar with this test. It's a great one. So effectively, what we're going to do is we're going to take the blood pressure using the cuff in the arm, in the upper extremity, using the brachial artery, and you're going to compare it to the one you took in the leg. So you're going to put the cuff around the ankle and then test the point at which you obliterate one of the ankle pulses, either the dorsalis pedis or the medial malleolus, if you can find it. And it's called, there it is, the ankle to brachial pressure index. And a fantastic test this is, the ankle to brachial pressure index. You take the two measurements, you divide the leg by the arm. So there's an example of it, and it should come out at around 110%, something like that. So the leg should be higher than the arm under normal circumstances. Now, again, if the person has some sort of peripheral claudicant condition, of course, that figure will drop. And this is an old-fashioned way of testing. I don't know many people who have a Doppler. It's a bit more sophisticated than that, as you can tell, and we can actually explore these vessels. But, oh look, there it is. Can you see the head? But it's a fantastically useful test to do. And in patients who have less than something like maybe 90%, there is a strong suspicion of peripheral vascular disease. If that level goes down to 60% actually, then there's also an implication of coronary heart disease as well. So if that number goes down below 60%, there's a very strong implication of coronary vessel disease as well. So there's a beautiful example of how you can actually derive tangible physical evidence that you can actually put in a letter to somebody, look what I found, as well as looking for your brew, which is a rarity, and just feeling the pulses, you actually get some sort of overt written evidence. And as it happens, that patient, the first case history I showed you, the property developer, he actually had such a poor ABPI, he actually did 6 months later, he did have a coronary attack. He had an obstruction MI bar. Right, let's just move on. Remember, everybody knows how to assess blood pressure. These, again, you'll have to look these up. They're based on the British Hypertension Society figures. Again, well worth reminding ourselves about. But some of these figures actually change. Look, they've actually started to bring things down. They want us to be less than 80 now. And this is also consistent with World Health Organization rules as well. They want us to be under 120 and under 80. So 120, 80 normal, optimum, lower than please if you can. Although they will tolerate less than 130 and less than 85. High to normal, you can see, look at those figures. I completely disqualified on this because I always white coat horrifically whenever I have my blood pressure taken, because I always hate those digital machines. So it's worthwhile familiarising ourselves with these numbers again, just remembering. But the fundamentals haven't really changed that much. And again, you can check the nice guidelines here. But I'll just double check these, and they're pretty much up to date. There are the stage 1 hypertension, 140 over 90. Stage 2, now they're saying 160 over 100. Okay, so diagnosing hypertension. And this is very interesting, actually. If the difference in readings between arms is more than 20 millimeters, repeat them. Now, nobody does this, but there's a huge amount of evidence for this. Look, if you test the two different arms at the same time, the difference in readings between arms remains more than 20 millimeters on the second reading. Measure the subsequent blood pressures in the arm with a higher, take the one with a higher reading, and if it's even higher, again, repeat third time. And again, they're saying both arms, but there's even more to it than that. Before I come on to that, remember I talked about the person with dizziness. I talked about POTS and the postural hypertension, and also the orthostatic postural hypertension. So a person has an increased effect. It's not just a momentary feeling of dizziness, but they really will faint. There's now this kind of this idea that with the history, you should test the person supine, get them to stand up for at least 1 minute prior to measurement, and then test again. So see if they still feel faint. If the systolic pressure falls by 20 millimeters or more, and the person standing, review them. They're saying review their medication, but take it seriously, effectively. It may need, and if you discover that, that will need referral. So again, this is to see if a person can recover within a minute standing up. If they don't, normally, as I said, you dump half a litre of blood, you might feel a bit faint, but that's the end of it. But if the person doesn't recover and they become tachycardic, it's a referral scenario. So here I was just talking again about this intra-arm blood pressure assessment. finding it out, one study said that it can reduce can actually reduce 10 years survival if they do have a big difference between arms systolically and it's not checked. But this is why now there's a drive for GPs to check it. I don't think it does it, but it does have a value. Differences of 10 millimeters of mercury or more are a greater risk of cardiovascular disease events and mortality. 246 Devon patients had blood pressure measured at 3 successive points and new cardiovascular events and deaths recorded prospectively. And they found that the 10-year follow-up systolic intra-arm difference of greater than 10 millimeters had a survival of cardiovascular events reduced on average by 5.5 years compared with 10 millimeters. So effectively, so if it was less than 10 millimeters. So now this intra-arm difference again betrays a kind of the notion of a kind of a broader cardiovascular illness. Unfortunately, GPs only have 7 minutes. We've got longer. It's the sort of thing that may be of value. I'm going to go through. I'm going to have to finish shortly, I think, so we can have a few questions. But this is worth having a look at. And again, I hope that our organisers today may make these slides available to subscribers if they want to. I'm not going to, I think, talk about too much of this stuff now. So, a little bit about automated blood pressure taking. There is a device actually available that's nice and approved, which is this one, that actually also picks up fibrillation. Again, I want to stress just how important fibrillation is considered to be now. People really think it's a vital thing to pick up, again, because of the possibility of raised potential mortality or morbidity, certainly. I won't talk about blood pressure. I'm sure everybody remembers how to take a blood pressure. I'm just talking about the Korokov signs and reminding people of Korokov signs, and bearing in mind that it's important to palpate and not just auscultate. Palpation is critical. So when you get to the top here, make sure that you are palpating it first. So palpate on the way up, auscultate on the way down, because of course sometimes you get a very extended or telescoped difference between phase 1 and 2, and you may not realize that phase 3 is actually where the sounds have come in. You may mistake phase 3 for phase 1 if you're only auscultating. Always palpate, because that's relatively infallible compared to auscultation, where the sound may vary. Just hopefully a reminder to everybody. Right, so I talked briefly about orthostatic tachycardic, postural orthostatic tachycardic syndrome. That was POTS. And examination of the chest. Remember where the lobes are, because you may want to listen to lungs, you may want to listen for fluid. Again, just a little reminder. So I thought I could leave time now if people want to ask questions. I have raced through that somewhat, but I hope that that was a useful reminder. With a few extra little issues, I think the peripheral vascular examination is important, and I think I think some of those ideas about blood pressure and hypertension are worth being kept up to date. Over to you.
Thank you very much, Barry. That was a fantastic lecture. Thank you. It was so much detail, and it's so helpful for all the osteopaths for the clinical reasoning. So I hope everybody enjoys so much. We have one question coming from Mervyn Wallman, saying, how would you treat any somatic component found in conjunction with cardiac disease, given the patient's consent?
Well, hello, evening to you, Mervyn. I remember you well. You're originally from one of the Hampstead guys, and I remember you coming to the BSO and actually demonstrating a kind of full body assessment for us all to look at under the invitation of Laurie Hartman. That was a long time ago. That was probably about 1985, I should think. I'm probably going to disappoint you, because I think it's very interesting. And we were actually talking about this at a symposium I was at the weekend. And I think there was a lot of talk about trying to implement notions of somatic influence by looking at sympathetic vagus nerves, particularly. They were talking about being important, how we might be able to influence the behavior of the autonomic nervous system by looking at the neck and so on. The problem I've got with that is, in principle, I don't dispute it, but I would want to see a little bit more evidence about the absolute physiology that we're describing. So yes, I'm absolutely sure that things like breathing behavior are critical. I think there's a great deal of emphasis once again on the notion of people's proclivity to drop their carbon dioxide levels if they become metabolically deprived of carbon dioxide, they become hypocapnic or alkalotic. it can actually influence cardiac function. I think there's a lot of consensus about that now. But actually doing physical stuff, right, the old-fashioned sympathetics, the stellate ganglia, remember that one? I can't subscribe to that because I'm not saying it's wrong, but I don't have sufficient current evidence-based to be able to say, yes, this is what I can do. And I'm welcoming anybody to please provide that. So nice big studies, evidence-based physiology. Evidence-based physiology, it says by fiddling and interfering with that thing, I can infect that. I have a hard enough time understanding the stuff I do, but I'm not decrying it in any way. I'm just saying I think it's a particularly difficult thing to address, and I think it's a deeply interesting and imaginative osteopathic position, and I think it's something that needs to be explored.
Very good, thank you. Someone was asking if you could show the slide of the peripheral pulse again.
Sorry, I'm missing that. Could you?
The slide that you put on peripheral pulse, you could show that one again.
Yeah, for sure. Yeah, I'll do my best.
Yeah.
1 second. Okay, let's see if I can come out of this. 1 second. I think the list. This one.
I can't see now.
Okay, have I lost it?
The one on peripheral pulse.
Okay, sorry, Diego. Hang on a second. I have to do the sharing again. Wait a second.
Yeah.
That's this. This one?
I think it was the video, the little video you have with the peripheral. Didn't you have a video showing?
Oh, not the location. Hang on, let me just move back and see if I can find it. They didn't want to. Can you be more explicit as to which one they meant, please?
I don't know. He didn't say much.
Could they at least give me a clue as to what they want to see?
Peripheral pulse.
Do they mean a list of peripheral pulses? Do they mean that list I just had up?
Maybe that one.
Hang on. Are we talking about? Where's it gone? It's the first thing I put up just now. This thing.
Maybe it's this one. Yeah. Okay. Oh yeah. Okay.
Oops. Okay, gone past now.
Yeah, and that's the one. He says that's the one.
Okay,
he just wrote.
This is again, this is the sort of thing that's particularly prevalent. You'll find this in so many different clinical examination books and so on. This is old-fashioned standard stuff.
Yeah. Okay. Someone else asking, Mahmoud asking, on your experience, what is osteopathic considerations to treat patients with atrial fibrillation? Okay.
Again, I have to refer you back to the disappointing response I gave Mervyn before, which is that at the moment I don't have anything because I don't believe that there is sufficient physiological evidence to support our intervention for arrhythmia. People talk about it all the time. They talk about trying to manipulate the thoracic spine and so on. But to be honest with you, I don't think there's anything sufficiently tangible that justifies our doing that. If I think a person's got atrial fibrillation, I think there's a huge wealth of resource there now and refined information to be gained through the conventional medical route. If they've got anything they can share in any physiological studies that demonstrate that we can do that. I'm not even talking about treatment. I'm just talking about even just the physiology, of any somatic relationship that has been well demonstrated and contemporaneously. I'd like to know what it is. In other words, can you crack T2 and eventually influence his cardiac function? I don't know if that is a real thing. We've talked about it for donkey's years. I'm not sure that it's actually a real thing. I'm not saying it's not a real thing. I would just like to know more about it.
Yeah, I agree with that. Do you have any relationship between sleep apnea and atrial fibrillation? Is there any relationship between both of them?
No. Not really, no. Well, sleep apnea has a lot of other. It's not my area of expertise. I have to say, it's not an area I know a great deal about. But sleep apnea is as everyone knows, a grave concern. It's worth looking up. Let's just have a see if I can find it. But it's not something I can talk about with any confidence, I'm afraid. Let's just see what's kind of. Actually, what I would actually say is not just atrial fibrillation. I would talk about arrhythmia as well.
Arrhythmia, yeah.
Hang on, sleep. I just say that. The only thing we can say is we know that, as I said before, sleep apnea, especially if you deprive the tissues of function, especially cardiac tissues of function, and there is an underlying proclivity to arrhythmia, then it's not going to do you any good, is it? And it's going to increase the risk of arrhythmias. But atrial fibrillation specifically, I wouldn't like to say.
Okay, someone, Michelle, is asking, do you make any standard cardiovascular examination to all your patients, or you just take the case history and that will indicate you if you need to do a CVS examination?
The latter. As soon as you start doing the same test on every patient without paying attention to the history, you are screening. And screening is an unthinking audit, in my opinion. In other words, you're not thinking about anything at all. It's hard enough to justify the things that we do, but to really just to perform an examination for nothing, I think, is actually not consistent with osteopathic or good clinical technique. Admittedly, in theory, there's an argument for taking blood pressure. A lot of GPs, if they haven't seen a patient for a while, will take blood pressure quite frequently, and there's a very low threshold to take blood pressure. But I don't absolutely try to be historically driven as much as possible, and so does my cat.
Okay. Thanks. Just reading the questions here.
Okay. I'm sorry. I think people are going to be quite disappointed.
Well, no, it's just the fact. So, how would you an osteopath is saying how would an osteopath be best positioned to help a patient with sleep apnea who was beginning to develop heart problem? He's asking this because sleep apnea is a deprivation of oxygen, and that will trigger a response in the cardiovascular system.
Yeah, sure, but how are you? I would have to say to you, have you got any ideas actually what sleep apnea even causes it? You know, yeah. That's the problem. You'd have to go back and say, look, effectively, it's a condition that actually has a predictable outcome, but we don't always understand where it comes from. And this is the trouble. You know, we're very good at understanding what the effects are, but where it's actually come from is a much harder, and why it's actually caused is a much harder thing to understand. Very, very difficult. I mean, one of the main problems you've got with sleep apnea is pharyngeal collapse, and that's going to cause immediate obstruction to oxygenation. Never mind about their heart. You know, it's a serious emergency condition. So, I think really to try and intervene with it is kind of a secondary consideration. And yes, there are lots of arrhythmias associated with it. People become tachycardic. They may develop sinus arrest. They may develop atrioventricular block. The trouble is, again, you know, it's an emergency situation at the moment. You know, even understanding it is very, very difficult. So I wouldn't say that we can just wade in and say, if I do X, it'll have a particular effect. We just don't know. We don't understand how to address it. But but again, there's plenty of evidence linking arrhythmias with sleep apnea. But again, where does the sleep apnea actually come from? Don't know.
Yeah, it's a wide response. Yeah,
exactly. So many and I think it's simplifying things to think that we can just pop something or treat something. You know, these are lovely ideas, and in time we may actually discover more about the way physiology behaves. But it's not something I'd care to want to intervene with because I don't think we understand it sufficiently.
Okay. Any diet advice to weight loss should be dietary advice in reference to weight loss should alleviate up to 70% of sleep apnea cases.
Okay, yes, weight loss. Yeah. If no one would dispute that one, very important.
That's maybe, yeah.
Obesity is the scourge of the West for sure.
Yes. Okay, very good. I think there are quite a few questions. People were very interactive today, and I think you, as I said, your lecture was so good, so in detail.
Thank you.
And we all learned so much. And
I'm sorry to have raced through it so quickly. There was quite a lot to cover, and even then I left a lot out. But I hope
it has been recorded, so people can can watch it again after that. It was
Good.
just
Okay, excellent.
a good reminder. And I must admit that it's very nice to see you after 15 years, and I have to say you look very well.
You're very kind. Thank you.
Yeah, thank you.
It's an interesting point that you make there, because that 57-year-old healthcare clinician was me. And just to finish off, actually, I had some epigastric pain on the cross trainer, which it subsequently seems to have been GI, we think. And yet, I went to the cardiologist and I said to him, I've got these symptoms. I don't really think they're cardiac, but I think they're worth exploring. He said, I don't think they're cardiac either. And I had a CT scan. I've had a couple of CT scans because one went wrong. And I had a 70% obstruction in my left anterior descending coronary artery, which they sometimes call the widowmaker. It's a kind of obstruction that causes someone to just fall down dead when exercising or walking down the street. And I had to have that stented. And I still had the indigestion.
Right. Well, but at least you found out about that.
Yeah, at least I put my money where my mouth is.
Yes,
but again, whether it was coincidental or not, nobody knows. We still don't know if the symptoms actually were reconcilable to cardiovascular function or not.
Yeah. Wow, nice example. Very good.
Thank
okay,
you.
everyone, thank you for logging in. And just to remind you that we still have some events coming up for the ICO. We have a workshop at the end of the month about the lymphatics. Another webinar in December talking about MS, multiple sclerosis. And next year, just the ICO conference, the annual ICO conference with Dr. Eric Schneider, Dr. Maribel from Spain, Tim Sparrow, and Christian Fossum. So we look forward to see you all there. And thank you, Barry.
Thank you, Diego. It's been a pleasure.
It was a real pleasure. And I'll catch you soon. Thank you.
Bye, everyone.
Bye-bye. Bye.